Hi, this is Dr. Kronowitz and welcome to What's Hot in Plastic Surgery. This segment I will discuss breast reconstruction. Let me first say that there are so many components of breast reconstruction. Really, to get the most information is to make an appointment to come in and see me for a consultation. But let me break it down to you for. Let's talk about breast reconstruction after mastectomy. One of the most innovative aspects and really one of the greatest achievements in mastectomy and mastectomy reconstruction has been the implementation of nipple-sparing mastectomy. Now, not all patients are eligible for nipple-sparing mastectomy. It depends upon how close your tumor location is to the nipple areolar complex. Other than that, in my practice, almost all patients are candidates for nipple-sparing mastectomy, even if you have the so-called ptotic or drooping breast. I have various techniques that I have developed in order to incorporate all patients, as long as there is not an oncology-related reason to not have nipple-sparing mastectomy. But nipple-sparing mastectomy has really revolutionized our approach to reconstruction after mastectomy. It allows us to simplify these procedures and to often perform them in only one operation, with a direct implant placement, the placement of an acellular dermal matrix, and then subsequent fat grafting, which could be done as a separate, second, very minimal procedure in an office setting. There are other ways of approaching. Of course, we can use flaps in nipple-sparing mastectomy, but often this is not the case because with flaps in nipple-sparing mastectomy, often we cannot camouflage the incisions. With nipple-sparing mastectomy and implants, we can place the incisions underneath the breast fold or in the lateral breast crease or the outer breast crease, and they're almost completely camouflaged. In many patients, even without clothing, it is very hard to know that a patient even had mastectomy. Now, many patients still receive skin-sparing mastectomy who are not eligible for nipple-sparing mastectomy, and we could still achieve significant, really nice outcomes with those patients as well. In those particular cases, often it is best to do a two-staged approach with implant reconstruction, with placement of a tissue expander completely covered with an acellular dermal matrix. Now, an acellular dermal matrix is actually skin from a cadaver with the cells removed. It has great advantages in that it provides additional coverage of the implant over otherwise very thin breast skin, which occurs from the mastectomy. It also has the potential of reducing hardness or firmness, or what we call capsular contracture, around the implant, and can have some effects as far as being protective as well. It does have a slightly higher risk of infection, but most of those infections are usually treated successfully with outpatient antibiotics during the postoperative period. So after the first stage and placement of a tissue expander and an acellular dermal matrix, often in those cases I will fill the tissue expander. So in my practice, you wake up essentially with a breast. And then we will go on, and during a second stage, approximately 3 to 6 months later, I will exchange for a permanent shaped implant. I prefer shaped implants. I use them exclusively in my practice, not only for reconstructive, but for cosmetic purposes as well. They result in the most natural outcomes and tend not to bottom out as many round implants do as well. So during the second stage, I would place the permanent implant in there and do extensive fat grafting, where I liposuction fat from somewhere else on your body and inject it into your entire breast skin envelope. This can result in an excellent outcome, and then subsequently perform nipple reconstruction along with tattooing with excellent outcomes. Of course, I do the most complex and innovative microsurgery available anywhere, and actually one of the top microsurgeons in the world. I perform very complicated DIEP flaps, which are essentially the same as a lower abdominal tram flap, but without any muscle. And I perform microsurgery using microscope and transfer it to the chest wall and attach blood vessels, then shape it into the breast. I use this very commonly for patients who receive radiation. I also have the ability to do very complex DIEP flaps, which I call a double DIEP flap, where I'm able to use the entire lower abdomen to provide adequate skin replacement. This can really be important for patients that either have who have a small breast and we want to get a larger size breast, and this way get more tissue to take on the chest wall because of the enhanced blood supply, or in patients that have already had a mastectomy and have no usable skin where I need to replace a lot of skin. I also take tissue from the buttock area and of course incorporate fat grafting in almost every patient that gets fat that undergoes breast reconstruction, either with implants or even with the use of flaps. So there's also many other issues to be discussed which will not be included in this segment, include how the integration of radiation therapy, of which I personally have developed many of the techniques that are referred to as delayed immediate and delayed breast reconstruction, and have currently been doing a very exciting technique which I think will change the approach to implant-based reconstruction in patients who receive radiation to make it safer with excellent outcomes. Well, I really appreciate you tuning into this segment on What's Hot in Plastic Surgery. I hope you tune into the next segment, and thank you very much, and hope to see you in my practice soon. Thank you.